Nuno Cardim will show how to perform an echocardiographic examination in patients with cardiomyopathies. He will focus on the most typical features that need to be examined to make the appropriate diagnosis.
What we are going to do today is to learn how to perform an echo in an hypertrophic cardiomyopathy patient. We are going to try to do it in a step-by-step approach in a clinical integrated way. This patient is a 22 years old male patient with a known hypertrophic cardiomyopathy. He was very symptomatic. He was proposed to surgery, but he refused surgery, and so he performed an ASA, an alcohol septal ablation procedure. This exam is going to be the follow-up echo after that procedure. Here we can see that in the left parasternal view, the first thing to assess is to assess anatomy and try to quantify the wall thickness, because it has quite some important prognostic implications. Here we can see that there is an asymmetrical septal hypertrophy. The septum looks thicker, much thicker than the posterior left ventricular wall, and we also see there is a SAM, systolic anterior motion of the mitral valve. In the same view, we can quantify the wall thickness, and we can see that septal thickness is important, is 18 millimeters, and the posterior wall thickness is only 7 millimeters. It is important in this view, try not to include right ventricular structures such as trabecula, papillary muscles or chorda of the tricuspid valve that can cause false left ventricular hypertrophies. In the same view, but in the short axis now, we must always try to quantify wall thickness. This is a cine loop, and after in the steel frame we try to measure every segment, try to assess the wall thickness and to assess the maximum wall thickness. With the transducer pointing a little bit lower to the apex, at the level of the papillary muscles, we must do exactly the same thing. This view is the classical and most indicated view to assess wall thickness in these patients, even though you must do it in other conventional and in other non-conventional views. And so trying to measure all the wall thickness at different segments. Now, in another plane, we move to the apical four-chamber view, where we can see the hypertrophic septum with a hyperechogenic ground glass appearance. We can also see the systolic anterior motion of the mitral valve, and in the three-chamber view, we can see that the SAM is very important, and some parts of the anterior and posterior mitral valve leaflets also come into the left ventricular outflow tract, and perhaps this is an important mechanism of intraventricular obstruction in this patient. Coming back to the four-chamber view, we can again assess anatomy and confirm that the septum is severely hypertrophic, and perhaps here the lateral wall is also with increased wall thickness. To assess the obstruction, we can come back to another view, to the left long axis parasternal view within an M mode of the aortic valve, where we can see there is mid-systolic closure of the aortic valve, pointing to an intraventricular obstruction. With the zoom, perhaps we can see it clearly, and now we can clearly see an early systolic closure, which is not specific of hypertrophic obstructive cardiomyopathy, but then in these patients strongly points to intraventricular obstruction. In the same view, again, the measurement of the wall thickness, and when we put color Doppler on the image, we can see aliasing, turbulence in the left ventricular outflow tract before the aortic valve, showing that the obstruction is really not in the aortic valve but before the aortic valve in the LV outflow tract. And we can see that there is also a mitral regurgitation to quantify according to the ACVI guidelines, perhaps moderate, but most important thing is the direction of this mitral regurgitation. When it is SAM related to obstruction, its direction is posterior and lateral, pointing to showing that the mechanism of obstruction is SAM related. When the direction is central or anterior, the direction of the mitral regurgitant jet, we must always think on an associated organic valve disease. When we make an M-mode cut of the mitral valve, we can confirm the systolic anterior motion of the mitral valve, which touch and has contact with the interventricular septum. You can see we are in systole, and it touched the septum in mid-systole, and the contact with the septum is long until teles systole, until the end of systole. This also points to interventricular obstruction. With color flow in the image, we can see aliasing in the SAM in the image shown before, confirming that the obstruction is there at that point. Coming back to the apical views, this is a still image, again, of the aliasing in the left ventricular outflow tract and of the mitral valve regurgitation jack directed here to the lateral wall, and a dynamic image with exactly the same data. And again, you can see the aliasing is in the left ventricular outflow tract, and you can also notice there a mild, very mild jet of aortic regurgitation. Another frozen image, and again, now I'm going to put the continuous wave Doppler to assess the level of obstruction, and here it is. This is the very clear image showing that there is an important interventricular obstruction. Look at the maximum velocity of 106 millimeters of mercury, and look at the dagger-shaped envelope of this envelope, which is very, very typical of this disease, hypertrophic cardiomyopathy with left ventricular outflow tract obstruction. Another one, always gradients above 100 millimeters of mercury, and now it's, even though it's not very frequent, it is rare, we always have to look for right ventricular outflow tract obstruction. So we move our view to the parasternal view, short axis at the level of the pulmonary valve. Everything seems okay, and with continuous wave Doppler, the velocity is mildly higher than 1, so there is no right ventricular obstruction at all. In the four-chamber view, we are now going to assess function. First, we have focused on anatomy and on associated findings. We assessed left ventricular hypertrophy, we have assessed obstruction and mitral regurgitation, and now we're going to assess diastolic function. This is a transmitral inflow pattern. The most important thing here is to assess the maximum velocity of the E wave. Very important, this pattern, the transmitral inflow pattern, specifically in this type of patients, hypertrophic cardiomyopathy patients, do not show these patterns good correlations with invasive measured LV filling pressures. So be careful, because you must interpret these patterns, the transmitral inflow pattern, be very prudent in interpretation of this data in these patients. When we move to Doppler myocardial imaging and you put the sample volume in the lateral site of the mitral annulus, we assess the early diastolic wave velocity, and we calculate the E2 E prime, which is 19, almost 20. According to the ACVI guidelines, this ratio in hypertrophic cardiomyopathy suggests high left ventricular filling pressures if higher than 12 in this patient. So this pattern clearly points to high ventricular filling pressures. This is just an example in the septum of this patient that the systolic velocity is low, and of course diastolic velocities are also low in this patient. Now I moved again to the fourth chamber view with color to measure the indexed left atrial volume, which is another important parameter, because it's, on one hand, it points to increased left ventricular pressures, and on the other hand, this increased volume has important prognostic implications in several diseases, including in this disease. Again, with color. Another important data is try to assess, also in apical four-chamber view, to assess the pulmonary venous flow, which is not often easy, not often executable and feasible, but in this patient you can clearly see the atrial reversal wave and measure its duration, which is 191 seconds from here to here. It's important to remind this figure, 191 figure, also to measure its velocity, 0.4 meters per second, and after to compare the duration with the duration of the A wave in transmitral inflow profile. So it was 191 the measurement of the A reversal wave in the pulmonary venous flow, and the duration of the A wave in transmitral inflow is 141. So the difference between these two parameters is 50 milliseconds. This value, this figure, when higher than 35, also points to increase the left ventricular filling pressure. So another of the four ACVI criteria for increased filling pressures in hypertrophic cardiomyopathy patients. The other parameter pointing to this is the presence of pulmonary hypertension. Now we change to the right heart. There is a mild, very mild pulmonary regurgitation, but there is a gradient AV, right V of 47, which corresponds at least at a pulmonary systolic artery pressure of 52, because the machine is set to assume that the right atrial pressure is 5 millimeters. Of course, we'll correct this figure later if needed. This is the assessment of the right ventricular function, the TAPS, which is 24. It's a preserved longitudinal right ventricular function. This is the dynamic view of the inferior vena cava, with showing that there is an inspiratory collapse, and so I agree with the machine and that the right atrial pressure was 5, so that the value we estimated for pulmonary artery pressure was okay. This is tricuspid annulus systolic velocity, another index, another way to assess right ventricular longitudinal function, which is here 12 or 11. It's borderline, but perhaps normal and in accordance with the measurement we made with TAPS. And now we're going to change the view and turn again to the left peristernal view to assess systolic function. In the eyeball assessment, everything seems to be contracting well. We know that the classical indices of systolic function in this disease show and say that these patients have normal or even supernormal systolic function. Now with the M mode, we can assess shortening fraction, which is 65%, which is normal or even supernormal as we expected. And moving to the 4-chamber view, we assess the ejection fraction by Simpson biplane, confirming high numbers, high values, high figures of ejection fraction in this patient. The figure was 80% of ejection fraction, confirming a supernormal index of systolic function. Very important, but I didn't do it in this patient because the obstruction was very high, is to assess in non-obstructive patients at rest also the indexed stroke volume, because most of these patients, as they have very small cavities, they may have, and they often have, very high ejection fraction but very low stroke volumes. Another type of approach of the systolic function would be with speckle tracking echocardiography in the apical view. Here is the 3-chamber view. One segment was not clear for analysis, and I'm going to exclude it in the assessment. In this view, only one segment, which is the basal segment of the anterior septum, is mildly anormal. -14 is a borderline value, but when we change to the 4-chamber view, we can see very important and very interesting findings. Just let me remember that this patient performed an ASA, an apical septal ablation, and perhaps it was in this place where there is almost no myocardial deformation. It's -2, which means that there is a scar there corresponding to the place where the alcohol septal ablation was performed. There are other segments, specifically in the lateral wall, with very low, below -10 strain longitudinal values. And in the 2-chamber view, again in the anterior wall where the ASA procedure was performed, there is a very low -2 regional longitudinal strain, and the other segments are okay. Overall, the global longitudinal strain in this patient is okay because most of the segments have regional longitudinal strain preserved, and here you can clearly see the area where the ASA procedure was done. So I think the examination can stop here. We have assessed anatomy, we have assessed obstruction, we have assessed mitral regurgitation, we have assessed diastolic function, and we have assessed systolic function with conventional and with non-conventional echo techniques. What we are going to do now is to learn how to perform an echo in a patient with a dilated cardiomyopathy. This patient, heavy cardiac past history, he has coronary artery disease, he had myocardial infarction, he was submitted to CABG and also during that surgery to mitral valve and tricuspid valve plasty, and but his heart is like you are going to see. In the left parasternal long axis view, you can see that the left ventricle seems mildly dilated. It's not contracting too bad, but not too well. I would say at eyeball that LV function is mildly depressed. And you can also see that the left atrium is dilated, as you can confirm with this 2D measurement. And of course, it's part of the examination to assess the diameter of the aortic root with M mode. And in still frames, you can confirm that the left ventricle measures in telediastole 65 millimeters, which means it is dilated. Also, you can confirm that LV walls are not thickened. There is no LV hypertrophy. The next step is to assess the left ventricular outflow tract for further measurements later, and you can see how we should measure the LV outflow tract diameter. Now we change to an M mode at the level of the mitral valve. We confirm the distance from the E point to the septum is increased. It's 23. The normal value is until 7 millimeters. And now we are going to assess the shortening fraction, confirming that in this view the LV is dilated and the fractional shortening is 20%. So our clinical impression, eyeball, was confirmed. It seems that the patient really has mild systolic dysfunction. In the same view, there is a central mitral regurgitation, despite the patient had performed mitral valve repair. In the short axis view, here the LV function seems more depressed than in the previous view. I would say mild to moderate in our eyeball assessment. When we turn to the four-chamber view, again, I would say a mild depressed LV systolic function, confirmed in the two-chamber view. I would say the inferior wall is akinetic. Perhaps he had an inferior myocardial infarction. And the three-chamber view confirms our overall previous impression. This is another way to assess the LV systolic function, the mitral regurgitation DPDT, which is the rate of change of the velocity of the mitral regurgitation flow between a velocity of 1 and 3, corresponding to the isovolumic contraction time when the contraction only depends on LV systolic function. The normal value is above 1,200, and this is, as you can see, 734, which is pointing to a depressed LV function. In the same view, with a pulsed wave Doppler 1 centimeter below, sample 1 centimeter below the aortic valve, we can assess the indexed stroke volume, which is about 30 milliliters per square meter. Just to remind you that the normal values, the normal figure is above 35, so it's depressed stroke volume. Also in the four-chamber view, we can assess the transmitral inflow profile. We can see that in patients with as we know, in patients with depressed LV function, the transmitral inflow profile has reasonable correlations with invasive measured LV filling pressures. This patient has a E wave higher than an A wave, pointing to pseudo-normalization pattern and pointing to increased LV filling pressures. His E to A ratio is high, but the deceleration time is higher than 150 milliseconds, so it is not yet a restrictive pattern. The E to E prime ratio is 32, which is huge, pointing and confirming what we were already expecting, very high left ventricular filling pressures in these patients, which we can also see the systolic velocity is really, really low. Coming back to the apical four-chamber view, and now focusing on the right heart. And before this, I will go to the subcostal view to assess the inferior vena cava, showing that it collapses with inspiration less than 50%, so I would say LA pressure is about 10 millimeters of mercury. It's not dilated. And another way to assess the left ventricular function is with speckle tracking echocardiography. In this patient, this is the three-chamber view. You can see that in the posterior wall, the myocardial systolic deformation in the basal posterior wall and in the medial posterior wall is very depressed, confirming that probably the site of the myocardial infarction this patient had was here. It was posterior inferior myocardial infarction. And this is the four-chamber view with speckle tracking assessment with several segments with very low values below minus 15 of regional longitudinal strain. Again, in two-chamber views, the inferior wall with very low values of peak longitudinal strain, and now the bullseye showing that the global longitudinal strain, the average is minus 10, pointing again to the depressed LV function of this patient. This is the right ventricular assessment of TAPS, which is 14, showing us that right ventricular systolic function is also depressed in this patient. Continuing the assessment of right ventricular function in dilated cardiomyopathy, we can confirm that tricuspid systolic velocity is low, is 9 centimeters per second, which is decreased. And finally, the conventional approach to the systolic left ventricular function shows that the ejection fraction is using the Simpson biplane formula is 41%, confirming our eyeball first impression and confirming also the speckle tracking assessment that the myocardial function, global function, was mildly to moderate reduced. So to conclude, I would like to say that this patient is a patient with dilated ischemic cardiomyopathy with mild to moderate depressed systolic function and increased left ventricular filling pressures. What we are going to see now is how to do an echo with a patient with a restrictive cardiomyopathy. This patient has familial amyloidosis. He received a pacemaker 3 years ago for severe conduction disturbances, and now is in heart failure, New York Heart Association 3. Of course, as we know, he has amyloidosis. We can suspect that he may have amyloid heart disease. We are not going to perform a complete echo, rather try to show you some tips and tricks, some specific features that can make us think of this specific disease. Because, as we all know, left ventricular hypertrophy is not a final diagnosis, it's the beginning of the investigation history. So to start, I'm showing you the four-chamber view, an apical four-chamber view of these patients. And we can see here very interesting findings, and we can really suspect of amyloid heart disease. We can see severe hypertrophy, which I would say it's at least moderate to severe. It's essentially concentric, but perhaps with septal predominance. It's important to notice this ground glass hyperechogenic appearance of the septum, which again is not specific, but must let us think about this disease. And another important thing is big atria and small ventricles, of course, which does not point to amyloidosis, but yes, to a restrictive cardiomyopathy. Another features, here is the lead of the pacemaker the patient received some months ago. A pericardial effusion is often quite common in amyloid heart disease, and also the interatrial septum, which is a little bit thickened. Sometimes it is described that these patients have hypertrophic interatrial septum. This is a still frame of the short axis view at the level of the aortic valves, where we can see that the aortic valve leaflets are thickened with some calcium, which is always typical of this disease, specifically in such young patient as this. And in the short axis view, you can see that the hypertrophy, and we can confirm our previous visual impression that the hypertrophy is essentially concentric, but with predominance of the thickness of the septum. So to conclude, I would say that in a patient that known amyloidosis, the diagnosis is easy, but in a patient without amyloidosis, there are some echocardiographic features that must let us think about this disease, some red flags. Just to say them again, the ground glass appearance of the septum, the interatrial septum hypertrophy, the pericardial effusion, concentric moderate hypertrophy, essentially concentric, and also not of amyloid heart disease, but of restrictive heart disease, big atria and small ventricles. Now we are going to see some clips and some images of how to do an echo and how to suspect of a Takotsubo cardiomyopathy. This patient came to us with a chest pain. He had a stressful event some days before, and despite not having risk factors for coronary artery disease, his ECG showed elevation of the ST segment in the precordial leads. Of course, it was obvious he had to go to the cath lab, but we performed an echocardiogram just before the cath lab. This is the apical four-chamber view, where you can see that the basal segments are very well, thank you, they are contracting okay, but the medial and apical segments, at least in all these walls, they don't contract at all, and there is a bulging, apical bulging of these segments. When we turn to the two chambers view, exactly the same impression. the basal segments of the anterior and inferior wall are contracting okay, but the medial and apical segments of the anterior and the inferior walls, they do not contract at all. And this is the parasternal view. Just a little bit more gain. And exactly the same impression. Basal segments okay, and the anterior septum is akinetic, as well as the medium segment of the posterior wall. Now I'm going to try to see just the short axis view, and is at the level of the mitral valve, confirming that LV function at this level is okay, everything is okay. And now I'm going to the apex, and the function is severely depressed. In the apical view, we assessed the ejection fraction, and it was, even though the evidence of this apical ballooning, the left ventricular function was in the fourth chamber view, it was okay, and the biplane Simpson's ejection fraction was 41%, so mildly depressed systolic function. This patient went to the cath lab, he performed coronary angiography, and the coronary arteries were absolutely, as we expected, absolutely normal. To conclude, I would say that this is a typical, very typical example of a Takotsubo cardiomyopathy, being the most important feature besides the normal contraction of the basal segments and the bulging and dilatic hypokinetic apex, the presence of the wall motion abnormalities have non-coronary artery typical distribution. It's not typical of any coronary artery lesion. It affects all the segments of the apex, and in this specific case also of the medial segments of all LV walls. Portanto, a non-coronary artery disease pattern. Thank you very much.
So what to look for in patients with cardiomyopathies? First, focus on the general cardiac anatomy. Describe the myocardial structure. Analyze the global and regional myocardial functions. Describe any ventricular obstruction or valvular regurgitation, and evaluate the pulmonary pressure.